Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, The Impact of Craniospinal Dose, Boost Volume, and Neurological Complications on Intellectual Outcome in Patients with Medulloblastoma by Iska Maksim-Imre and colleagues. My name is Daniel Armstrong, and I'm the Executive Vice Chair of Pediatrics and Director of the Mailman Center for Child Development at the University of Miami Miller School of Medicine and Holtz Children's Hospital in Miami, Florida, in the United States. My oncologic specialty is pediatric psychology. Prior to the early 1980s, treatment of medulloblastoma was restricted to surgical resection and high-dose cranial radiation therapy. The outcomes of this treatment were evident. Survivors were short in stature, often had thyroid failure and growth hormone deficiency, and almost always experienced some form of long-term cognitive impairment. The outcomes were severe for young children. This observation led the pediatric oncology group to modify treatment by delaying cranial radiation therapy using what was considered at the time to be adjuvant chemotherapy for children under 4 years of age. Mulhern and his colleagues in the pediatric oncology group also reported a relationship between age at time of treatment and cranial radiation dose on the severity of neurocognitive function in medulloblastoma survivors. Younger age and higher radiation therapy dose were associated with poor neurocognitive function, but this improved incrementally with increasing age and reduced radiation dose. These observations led to a number of changes in therapy for medulloblastoma, including increased reliance on chemotherapy as a primary treatment modality, different radiation therapy delivery strategies, and reduction and even elimination of radiation therapy for low-risk patients. One of the strategies to preserve survival and neurocognitive function has been to reduce cranial radiation therapy and substitute a total posterior fossa radiation boost with a conformal boost to the tumor bed. This strategy limits radiation exposure to the non-diseased tissue of the brain, and it is hoped that it will also preserve long-term neurocognitive function. To evaluate the benefit of this strategy, Iska Maksim-Imre and colleagues at the Hospital for Sick Children in Toronto, Canada, conducted a retrospective review of 113 patients treated for medulloblastoma at their institution between 1983 and 2011. 113 patients consented for the study and had neuropsychological evaluations using the age-appropriate Wechsler Scale of Intelligence after completion of treatment. Of this group, 51 were treated with standard dose craniospinal radiation with a posterior fossa boost, 9 with standard dose craniospinal radiation and a tumor bed boost, 28 with reduced dose craniospinal radiation and posterior fossa boost, and 23 with reduced dose craniospinal radiation and tumor bed boost. Chemotherapy was not used consistently as part of the treatment. Hydrocephalus requiring a ventricular shunt occurred for 54 patients, and an additional 40 had other neurologic complications, 25 of which were postoperative mutism, also called the posterior fossa syndrome. Maksim-Imre and colleagues report a number of confirmatory findings and some important new observations. First, all children with medulloblastoma had cognitive function below the normative mean, supporting the observation that these children continue to be particularly vulnerable for cognitive late effects. Second, the cognitive trajectories of the children treated with standard dose craniospinal radiation with posterior fossa or tumor bed boost and those treated with reduced dose craniospinal radiation with posterior fossa boost all declined over time, regardless of the intensity of treatment or the presence of hydrocephalus, mutism, or other neurologic complications. This is consistent with both prior observations and models of neurodevelopment for children treated with craniospinal radiation, that emphasize the importance of understanding cognitive late effects from a developmental perspective. The late effects of this treatment are not only acute, but are often characterized by ongoing declines in function many years after treatment is completed. Third, and most importantly, although functioning below the normative mean, children treated with reduced-dose craniospinal radiation and tumor bed boost had stable trajectories for cognitive function over time, while declines of at least 1.4 points per year were found for patients who received the other treatments. Working memory, a common cognitive late effects problem, was significantly better for those receiving reduced dose plus tumor bed boost than the other treatments. Fourth, children treated for hydrocephalus compared with those without hydrocephalus had poorer overall cognitive function, significantly poorer perceptual reasoning, and their verbal comprehension declined an average of 4.2 points per year. Finally, patients with other neurologic complications had poorer cognitive function than those without, and this was true for mutism as a specific condition. As with the early pediatric oncology group studies, this retrospective study provides evidence to support modifications of treatment for the purpose of preventing neurocognitive late effects in children treated for medulloblastoma. Of course, the primary goal of therapy is to increase survival. However, in studies so far, the use of reduced-dose craniospinal radiation therapy combined with chemotherapy and alternatives to full posterior fossa boost appears to have had no significant survival difference from conventional therapy. Mox and Emery's observations suggest, however, that there are clear late effects benefits with reduced-intensity radiation therapy approaches. Some children with medulloblastoma will have complications of the tumor and treatment, including hydrocephalus and mutism. Mox and Emery and colleagues confirmed early observations that these children are at increased risk for neurocognitive deficits, and they highlight the importance of standardized monitoring and support as part of their standard of care. Of course, the observation that all children with medulloblastoma, regardless of the intensity of treatment, had neurocognitive function below normative means emphasizes the need for this kind of support for every child with this disease. These results provide support for future clinical trials that systematically reduce the intensity of radiation therapy exposure, sustain current survival outcomes, and focus on improving long-term cognitive outcomes. This paper suggests that using reduced-dose craniospinal radiation combined with tumor bed boost is one strategy to accomplish this end. Others may include proton beam therapy, development of new chemotherapy combinations, immunotherapy, or tumor vaccines, but each of these needs to be evaluated both for effectiveness in treating the tumor and the level and trajectory of neurocognitive impairment after treatment. Fortunately, we have a track record of modifying treatment for medulloblastoma both to improve survival and to reduce toxicity and long-term suffering. Mox and Emery and colleagues provide a convincing, evidence-based argument for doing this once again, as long as we don't sacrifice survival. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.